we're delighted to have some rather excellent panelists with us this evening to talk about what is happening with in the world of robotic surgery. And we're just waiting for Sarah and Shahid's video to come on. Oh, here they are. Almost. Try again, guys. There we are. Oh, we see you. It's great to have you. Thank you for persevering with tricky Zoom links. I was just saying to people, we have already got our first lesson for our first webinar tonight. But delighted to have you all here. We are glad to be able to have you along so we can tell you a little bit about the work of Oracle, but most importantly, hear from 4 excellent panelists this evening to talk about how robotic surgery can really help people with head and neck cancer. And we'll hear from Shahid, who has had that surgery himself, so knows intimately what it's like to go through this. And we'll hear from Professor Vinidh Paleri and Dr. John Hardman, who are both at the Royal Marsden Hospital and are pioneering this area of treatment. So we are starting a little later, so I'm going to start with no further ado. We've had plenty of ado already this evening. So Sarah and Shahid, I'm going to ask if you could unmute yourselves, because I'm gonna have a chat with you to fill us in on what it's like to be on the other side of the robotic surgery. Thanks for joining us this evening. How are you both?
Yeah, all well. Yeah. Trying along. So, yeah, what's it like on the other side of surgery? Well, yeah. Obviously, I initially had radiotherapy to start with before I had the surgery, which obviously had an impact on the surgery itself, which no doubt Vin will be able to explain. But I mean, the surgery certainly removed the whole tumor. I'm now 5.5 years on from there, and working, living normally.
That's fantastic.
Handicaps, but apart from that.
So can you tell me a little bit about the beginning of your journey with head and neck cancer? You know, how old were you? You know, Sarah's with you now. You have a family, busy life. Yeah. What was going on for you when you were first diagnosed?
Well, what happened was the initial diagnosis was 2013, and long back. What happened was I spat out some blood, and just after Christmas or something, and or before, and I thought, oh, fishbone or something stuck in my throat. The second time I spat out the blood, Sarah saw it and said, "We've not had fish or anything like that, so how can we have a fishbone stuck?" So she immediately made an appointment with an ENT surgeon to see what the problem was. Now, I would say for all the men who are here, it's a typical male thing, oh, built blood, not bothered, carry on, and can't be much. But check it if you have anything so unusual as that. So obviously I had the initial scan, and it showed up a slight spot there, and then I was immediately transferred to Marsden, and obviously they do all your checks and all, and you then look them up. It was
2 centimeters carcinoma.
What's it called?
Squamous cell carcinoma, but HPV negative.
That's quite the news to be hearing. How did you feel about that at the time? It sounds like it was a bit of a shock.
It was a shock, but obviously you're in the rush of having everything done. So you don't sit down and spend too much time thinking about it. And it's not in my nature to why me, what happened, how did it happen to me? It's no point. There's no answer to the question.
Shahid, can I just say one thing? But it does happen to all of us, all around him. We were all the time thinking, what did we do? You know, were we having too much fun, drinking a little bit too much? Things like that were going through our minds that, you know, what is it? Obviously, Shahid's one of these people who's very positive. So, right. Go.
Yeah, so I just said, view that, right, it's happened, let's deal with it, move on, look forward rather than try and delve into what happened. I'm never going to find an answer to it, so move on. And so obviously I ended up with the Marsden. With radiotherapy, what happens is they remove all your lower teeth from the lower jaw. So the radiotherapy impacts on the bone. So they say it may cause a problem later on. That happened. And then I went in for my radiotherapy. That was 6 weeks of it. Monday to Friday, every day for 6 weeks. That's a long haul. And first couple of days, you're fine, but as it moves on, it gets harder and harder, especially being bolted onto a bed with your face is covered to stop you moving around. Whether it's changed much since then, I have no idea. Obviously, having gone through that, it takes quite a while for you to recover from all the burning sensation and everything. And taste of food and all is non-existent. Actually, eating is a problem in itself, because your inside is so burnt up. And a lot of loss of weight. They obviously say that radiotherapy has an 80% success rate. Unfortunately, I was on the 20%, so it didn't work out. And almost a year later, when we went for a final scan, it showed that tumor was still there.
Exactly the same size, actually. Everything was the same, as if it had not done a thing except for burn all the rest of his neck.
At which stage, they said, right, the only choice is the commando operation, which is to take everything out. At which time, that was a shock. Now, on the second time, it was quite a shock. And I took a view that, right, what if I don't have this operation, if I don't have the commando, maybe I have a few years to live, I'll enjoy my life, and what happens, happens. But of course they turn around and say, well, if you don't have it, you have 6 weeks left to live, which was
6 months, yeah. 6
months, sorry, yeah. Which was a complete shock to the system. So we went with the view that, all right, supposed to decide a friend of ours who's an ENT surgeon, and he said, right, I have a friend of mine who knows who does this, have a word with him. So hence we ended up with Vin up in Newcastle.
So this is why it's quite special as being able to have you all together this evening, because Vin and John were both involved in your surgery, weren't they?
Yeah.
So
yeah, so in fact, we were in Croatia when this decision was made, and from Croatia we spoke to Vin. I remember we were going around in the car and couldn't get the signal every now and then, but that was how we started. And then we came straight back from Croatia and went up to Newcastle to see Vin. And then there was a big issue about whether all the teeth have to be removed because of the opening of the jaw, and whether the robotics would be able to approach the tumor with his mouth open wide enough.
Yeah, but obviously it's damaged because of radiotherapy, so your mouth opening is much more constricted. So we went through a whole lot of processes there, and I'm sure Vin will explain to you the decisions he came up with and the procedure we then followed. But so that's where I started my journey on robotics.
Wow.
And I remember asking Professor Paleri then how many operations he'd done like this on secondary cancers. And he said, Shahid will be the 6th person with secondary tumors after all the radiotherapy. So I thought, well, 6 is my lucky day. I said, that's fine, my lucky number. So I said, that's okay. I'm sure that's a good number to go on.
So you really were quite a pioneer, weren't you, Shahid? I mean, how did you feel when you're on the cusp? Yeah,
I had no choice. I had to put myself in first hand.
Now, as soon as Professor Paleri told us everything, we were very impressed with the whole thing, and we thought, this is the man. We have to go with him. Yeah. So that's how we ended up having this, and touch wood, he's been so well, and now like eating meat and all this, we were told that maybe never be able to eat very much, but he can eat steaks. I remember the first steak we ate, we were in Switzerland, and we phoned up in to say he's had his first steak. I still remember that.
I remember that.
Wow, amazing. So what did it feel like the day before your operation? How were you? It sounds like you had obviously well-founded, good faith in the team that were going to be performing the surgery, but what was it like for you?
Well, like I said, I was trying to look forward, but then I said, look, once we go in there and we find that the margins are not sufficient, we still have to do the commando. So you go in not knowing the outcome.
Yeah.
So you're not sure when you wake up where you're going to be. So, and because I run my own business, I had to wind down everything before I went in for surgery.
You had to prepare for all eventualities.
Yeah, but obviously if I come out unable to talk or function, what's going to end up happening with everything? So different decisions are made, and that's where all the problems really occur from. But yeah, when you go in, you go in hoping for the best. I mean, you might come out, you might not come out at all. You don't know, isn't it?
Yeah. Well, that's quite a thought to leave us on, because I think this might be a good moment, and you, with the idea of you on the cusp of surgery, having to consider all these options, to hand over to Vin and John, actually, to tell us a little bit about the surgery that you actually went through.
Yeah. Thanks, Teresa. Thanks, Shahid and Sarah. It's good to see you both, and thank you all for signing in at this relatively late hour in the evening. What a fascinating story. Each time I listen to you, my hands stand on end. And in many ways, Shahid, your journey and my journey into using robotics for recurrent cancer, they almost started simultaneously. So I'd done a few patients before you with very small numbers. The data was just emerging. We hadn't done that many. And by the end of this 20 minutes, if you listen to what John has to say, so we've taken it to a completely different level where we have now data. John's going to present data that will show you that robotic surgery for recurrent cancers, where feasible, must be made the standard of care. And that's what John said. So we finished an international study from 16 global centers, collating individual patient data updated to the last month to show how effective this is. And just to be politically correct, we're both vaccinated. We both live in a bubble anyway, the Marsden, so we're not wearing masks. So, so I'm really, thank you for sharing your time, your story again, and your time. So over the next 20 minutes, I'll take you through some of the basics behind why cancer recurs, what we do for head and neck cancer, and of course, for some of you who haven't experienced head and neck cancer, what exactly it is, the issues we face with recurrences, and the steps we have taken within the Royal Marsden with the support of charities like Oracle to really push the recurrent cancer agenda, and where we are with things. So this might give you a reasonable idea. I've got some slides, but the slides pale into insignificance compared to Shahid's story, I must say. We'll try and get this going. Can you see my slides?
Yes, all good.
Yeah. Yeah. So for those of you who are relatively new to head and neck cancer is one umbrella term, but it actually involves many, many sites within the head and neck. And the reason why it is important to understand this is because a tumor at the front of the tongue, which is a few millimeters away from the back of the tongue, behaves differently. So the one at the front is a different beast compared to one at the back of the tongue. They need radically different approaches to treatment. A tumor, which is in the voice box on the vocal cords, is totally different to one which is a few millimeters above the vocal cords in a part of the voice box called the supraglottis. So while we have one umbrella term, the point I'm trying to drive at is that these are 8 to 10 different cancers that each behave differently despite their proximity. And to add to things, the neck is a fairly complex area to operate on. There's a lot of clockwork in there. We have so many nerves that work, the face, the voice box, the swallowing, all crucial functions to expressing that makes us human. And there are big blood vessels around there, especially important ones that carry blood to the brain, to the eyes, and understandably, we have to operate in such a way that we not only get a good margin around the tumor to ensure that we do an operation that is that cures cancer, but also we need to ensure that the patient on the other end has a good quality of life and good function after the operation, which is why there's a constant balance to be struck, a battle between how much to take, how much to leave behind, and to ensure that the cancer is cured in the process. So traditionally, we've had several arguments about how we should do this and what's the right way to do it. But these are things we have brought out in the recurrent cancer theme that John is working on. So we'll touch upon that when John speaks about this. But for some background data, it is the 5th most common cancer in the UK, with 16,000 new cases per year. The numbers have increased in the past 10 years, primarily driven by the human papilloma virus, which affects the back of the throat and lives there for a while, and then decides one day to cause cancer. Between 20 and 40% of cancers, and I can't give you a firm figure because, as I said, these are 8 to 10 different sites. So some cancers respond very well, some don't respond well, and depending on the nature of the cancer as well. In 20 and 40% of cancers will come back after treatment. But then when they come back, we have a problem in that patients already had fairly aggressive therapy. The first treatment for head and neck cancer is quite aggressive, both surgically and by radiation therapy. If you compare lymphoma, for instance, the radiation lymphoma patients get standard radiation therapy dose would be 30 grays or so. But the standard dose for head and neck cancer is 66 to 70 gray. So you can imagine it's almost double the dose, and therefore the toxicity is double. Likewise, surgery, for reasons I mentioned earlier, is challenging. So if it's challenging the first time around, you can imagine the challenges the second time around. We will be operating in a complex field, which is scarred, and therefore significant expertise is required to deal with these tumors. And additionally, because most of us are comfortable dealing with primary cancers, because by the time recurrences occur, time has moved on, the some patients don't want any treatment, the expertise may not exist. So there is significant disparity across the country in deciding what's the right treatment for some of the recurrences. Very few centers use novel therapies, and to compound, to make things even worse, we don't have good national data for recurrent cancers. We have decent data for primary cancers, but when cancers come back after treatment and they get, and we're planning for second line of treatment, we have poor data to guide us. So that's why when I started at the Marsden 4 years ago, I sat back and thought about what I should do for the next 10, 15 years before I retire. And I thought, let's focus on recurrent cancer. The best way to do that, in the absence of a dedicated focal point for recurrent cancer, I thought we should create a center. So I went about looking for money, and I was fortunate to find very generous people who have given us a substantial support, extremely generous, to set up an international center for recurrent head and neck cancer, which we are calling IREC. So we have multiple aims. This slide just tells you what the aims are. But essentially, we want to we don't want to do extra surgery and provide extra treatment, but we want to be able to support local centers in offering the newer treatment, in advising them, and creating an environment, an ecosystem where we can offer a rapid virtual second opinion, and at the same time lead as a vanguard center on delivering innovation in surgery, in novel non-surgical treatment and other treatments, and train future clinicians. So that's essentially what IREC is about. So this is where when we started doing this, we thought, okay, Shahid was an early pioneer, and thank you again for setting me on this journey. When we thought, let's look at, so we've been doing robotic surgery for a while now for recurrent cancer, but it's never been properly analyzed using a multi-center, robust setting. So like most things, research is prone to bias. People tend to report good results, not so good results are usually shoved on the carpet. So we wanted to do it in a much more robust fashion, pick out all the warts and all, and figure out, does robotic surgery really work? Does it work in multiple hands? Does it work equally well in multiple centers so more people can use it? So that's the aim of the recut study that we commenced, and we now completed that, I'm pleased to say. iKnife is another piece of PhD work that's going on, and recut's gone into many spin-offs. Like most successful entities, you get spin-off from successful enterprises. And then I'm now going to look at the other extreme of it in patients who can't be offered robotic surgery, because robotic surgery is applicable to a certain proportion. What do we do for a patient who needs substantial open surgery? They're fit, they're young, cancer has come back, and the sole option they offered many times is just chemotherapy alone, which controls for a certain duration, and after that doesn't. With the success of recut, we've learned so much, and we're going to apply that to procedures where sadly the voice box and the tongue will have to be removed with significant functional and quality of life issues. And that's never been done in a prospective, robust setting again. So this is broadly what we intend to do. So I'm going to quickly talk about robots before I hand over to John. Many of you would have seen these pictures. I won't labor upon this robotic surgery here to say, but it's not just me saying it. When the Royal College of Surgeons put together a document on the future of surgery with lots of stakeholders, professionals, futurists, and the industry, they all came together. It was very evident that robotic surgery was here to stay in the short term, in the longer term, and most importantly, to allow us to offer better care to patients by reducing variation in surgical performance. And that, in many ways, is also a theme for this afternoon. And for those of you who may not have seen it, that's kind of a theater setting where we're doing it through the mouth as a robot docked into the mouth, and the operation is going on with the surgeon sat in the corner. This is one example of a procedure of a throat cancer being removed in combination with a laser. And we do have, just for completion's sake, this is a fairly new model that has been released, and we're yet to trial this in Marsden, we hope to do that at some point, where instead of having multiple arms coming in, it's a single port, which is then used to deploy the different arms. And that's a camera coming off. The whole thing is being controlled by a surgeon. So that gives you an insight into why we're performing minimally invasive surgery. And I'm going to hand over to John to talk about some aspects of minimally invasive surgery. Thank you, John.
All right, thanks. Thanks very much for joining everyone. So I'm John, clinical research fellow working alongside Prof at the Marsden. And really just wanted to give you some idea as to, as Prof said, as how far things have come from when Shahid was being considered for his surgery all those years ago to where we are now. And very recently, we've led on a what we call the RECUT study, which is looking at doing transoral robotic surgery in patients who've had previous radiotherapy and then have another cancer in that same site. So they don't have the same treatment options available to them in terms of further radiation therapy or chemotherapy there. And so we're looking for curative options in surgery. TORS is really up there with leading as the minimally invasive approach. So these 16 international centres have kindly contributed data on nearly 300 patients. And really just wanted to give anyone listening or anyone watching the idea that these are options available to you. If your cancer is persistent or it comes back after you've had your original treatment, then there are options available to you. So the patients that have contributed to this international study have a great range of ages and both sexes. We see that some of them, about a third of them, are within 1 year of their original cancer, so it hasn't gone away, it's persisted, and they're being considered for further surgical options. Around a third of them are within 5 years, which is a kind of standard follow-up period that we may give you after you've had your original treatment. But around a third of them are also new head and neck cancers, whether that occurred within that 5-year monitoring period, but just in a different site, still within the head and neck, or whether it's at a later stage. About 1 in 7 of our patients were over 10 years from their original cancer when they had a further cancer come back in this area and they had to be considered for further treatment options. The majority of these cases that we're doing are in the oropharynx, which is the back of the tongue, the tonsils, or the back of the throat. And the majority of the ones that are getting surgery at this stage are early stage, so they're not too large and they haven't progressed, they haven't gone outside of the back of the throat. And as Shahid indicated, they're mainly squamous cell carcinomas, although not exclusively, and there are other types of cancer that we still take away and still operate on for this. And around a third of those are HPV positive disease, so they're related to this virus, which we think can confer better on patients. So if you are considered for this kind of surgery and something that's offered to you, around a third of our patients also have some kind of reconstruction. So either a free flap, which is some tissue taken from elsewhere in the body, and then plumbed into the blood vessels in the neck, and to try and reconstruct that area, or what we call a pedicle flap, and that's normally taking some of the chest tissue, some of the chest muscle, flipping that round to cover that area to encourage healing. Around a third of our patients will have a tracheostomy, which is a breathing tube inserted through the neck around the time of surgery, and that's principally just done for safety. That's not something that's a permanent solution, but we know that there's a risk of bleeding and sometimes problems with breathing, with swelling immediately after the operation, and the majority of our patients go away without a tracheostomy. Probably only around 5% of patients maybe have a tracheostomy in place even at a year afterwards, so really in a minority. And around a third of patients around the time of operation will have a feeding tube inserted through the tummy wall straight into the tongue, just to assist them with their feeding when we know that their swallow will be affected in that early period. There's a lot that we have to do to work on our rehabilitation with our speech and language therapy colleagues to get us going back to the use and function. And talking about function outcomes, I say, like by 1 year, we have 9 out of 10 patients tracheostomy free, and that varies per centre. And around 2/3 of our patients have a gastrostomy free. And in terms of survival, and this is all survival. So you're bearing in mind that patients who have this kind of surgery are normally in advanced years as well. So there's other things that can affect that. But over 70% of patients who've had the surgery are still with us at 2 years, and over half of them are still with us at 5 years after the surgery. And although those can be encouraging numbers for some, they may also be scary numbers for others. But they really are significantly better than a lot of the other alternative treatment options that may be offered to you if you do have further cancer that's come back in an irradiated field, where historically the options for treatment are quite limited. So that's just a quick run through of where we're at with that 16 centre study. That does build on work that we looked at when we did a systematic review, which we look at all the published data for that, which we looked at last year, a couple of years ago now, which is really just supporting the idea that these numbers are fairly solid and that we can be pretty sure about those as we counsel patients and talk to you about what to expect from further surgery if it's offered. So I'll briefly talk about other types of the studies that we're doing as well, and other things where we may move to in the future to try and benefit patients who have cancer that comes back. And one of those is working with Jim Higginson, who's a PhD student, who's looking at using something we call an eye knife. And it's a very clever instrument that, as we use our electric instruments to cut and to cauterize the tissue, it creates a little bit of smoke during the operation. And he has a spectrometer that can smell that smoke and try and work out whether you're cutting through normal tissue or whether you've strayed into cutting through cancer tissue. So one of the big complexities and challenges of doing surgery in our patients who've had previous radiation therapy, previous head and neck cancers, is that the tissues don't behave like normal. They don't look like normal, they don't feel like normal. And so this can be one tool we're hoping in the future that can help us to make sure we get clear margins and we can take away all of that disease for the best chance of survival and recovery afterwards, after the operation. So that will be, that's in progress at the moment, but it will be delivering results in the next few years. Another study that we're doing with Dr. Ben O'Leary, who's hopefully going to be a new appointee at the Marsden as a clinical oncologist soon, is looking at molecular analysis, so looking at the DNA of patients who've had cancer that has come back, and seeing if we can learn why some cancers are able to evade radiotherapy, as in Shahid's case, or why they've come back at a later stage, whether there's anything different about that cancer or about the whole area in the back of the throat or the upper area of the digestive tract that may mean that we can identify future targets and future treatments that can help out these patients. So again, that'll be reporting in the next couple of years or so. And one final study to mention is just that unfortunately some patients do have a risk of bleeding after this type of surgery. As part of the nature of the operation, we have to expose some blood vessels, and at present we also do a little operation on the neck to clip off some of those vessels that are feeding the tumour, to try and reduce the whole blood flow to that area for the recovery phase. But we're hoping that with the HELPER study, we'll be able to do what we call an embolization, which is where we go into the groin or into the wrist and go within the vessels, within the arteries, and try and block them off from the inside to try and save our patients that morbidity of the operation and the extra healing that can create and the complexity of that. So that's really a summary of all of the kind of minimally invasive surgeries and things that we're looking to try and improve on. I'll just make note of, I think Prof may want to build on slightly, is that we're also looking to try and identify patients at the other end of the spectrum. So traditionally, if it wasn't something that would be amenable to more local resection, if it needed more drastic surgery, we may not offer patients that kind of operation, thinking that the morbidity and the functional outcomes that, in terms of swallowing and voice may be too much to bear. But really, we want to work with patients now and to understand if we can go through informed consent and understand what patients would really desire from this and how important survival and function is to them, to understand which patients may want to be offered this more drastic surgery if it is something that can improve survival. So I'll pass back over to Prof.
Thank you, John. Teresa, I have little to add. That's our team at the Royal Marsden. We have some team members signed in, and a nod to the team members, Kira, who was here before and helped us in the early days with these things. I'll hand over to you, Teresa. I have little else to add. Thank you again for inviting me and John to share some of our interesting and groundbreaking data on this. Thank you.
That's great. Thank you so much, Vin and John. That has been really very interesting. We've got questions coming through from people. Just wanted to say, if anybody's got things that come to mind, drop them in our chat box or in the Q&A box, and we'll make sure we save a few minutes at the end to ask them. But before we do that, I wanted to come back to Shahid and Sarah and just come back to part of the story where we paused, really, where you were just before having your surgery, you were thinking about all these different options that you had to consider. And Shahid, I wondered if you could tell us a bit about what it was like when you woke up from your treatment and what your recovery was like, because John was talking there about how different things could be done to help support people through their recovery. We need to unmute you, if that's okay.
Wow. When you come out of it, obviously you're not completely with it. You tend to be quite heavily drugged up, so you're not also heavy with it. But I had a nasal tube for feeding. Obviously I had a tracheotomy as well. It was a very messy affair. But it was forever leaking, because obviously I had the radiotherapy, so the tissue was poor. But yeah, I mean, for quite a while, you're not, you're just sleeping most of the time. You don't really end up considering issues like tomorrow or what's on TV or any other sort.
I think the other thing was because Shahid had to have a mandible splitting operation because of the jaw restriction. Therefore, it was, I think, more difficult because everything was much more. For those people who don't have to have a jaw splitting, it's probably a bit easier, isn't it? So I think that was one of the other things, because he also had his lymph nodes and everything removed. I think overall he had this fistula, because there was a lot of discussion about the flap, whether you're going to put a flap in or not put a flap in. And Vin said that putting in a flap may actually reduce the mobility of the tongue and make it more difficult. Therefore, although there is a risk of a fistula, and if that happens, then we'll go back and do a flap. But initially, I think Vin's idea was don't put a flap in because there'll be less fibrosis and it'll be easier for Shahid to talk and move his tongue and eat. And I think that was the right thing that happened. And yes, it took a bit of time because when we came home, we had this bag attached to this fistula, and all the time pasta and everything was pouring into this bag and filling up. And we thought, oh my God, will this ever finish? And then he obviously had he initially had a nasogastric tube, but it would take 14 hours every day to be attached to a nasogastric tube to be fed every single day, which was just horrible. So in the end, they decided to put back stomach, a peg. And so he was then fed with that, which was much easier. He would just take a syringe and feed himself. Otherwise, 14 hours attached to this pump, which was going on and on, was just horrific. So it was all, even he couldn't drink water or anything at that point. So he had to feed water, everything through the tube. So all of that was we didn't think about all of that. We think operation done and you'll be fine. But
and obviously you can't talk. So any communication was all written.
Yes.
So in whatever discussion I had to handwrite it all.
Goodness me. So you said, Sarah, then you know, you couldn't, and you said, Shahid, you weren't speaking at that point, you weren't swallowing water or anything. What sort of milestones did you celebrate as you were recovering? Because it sounds like it was a fairly major undertaking.
Yeah, water is one, but water comes in much later. Even getting out of bed, having a shower, going to the bathroom. I mean, first time stepping out of the bed, the amount of muscle loss and weight loss is enormous. You hardly have the strength and the energy to do that. So step by step, you step up, you sit down in a chair, rise in the bed, next step, you know, once they took off the nasal thing, then learning to swallow. The first time I had water after operation was almost about 5 weeks later. All they do is they put one of those pink sponges, a little bit of damp, you wipe your mouth, and that was all you had. And when I first swallowed water, I choked everywhere.
Oh.
Because you've lost control. Well, you have no control because obviously all that's been removed. So gradually you move on and you start talking bit by bit. To now where I have no problem spending half the day on the phone. So, but even eating initially was all stodge. You know, you'd mash it all up, liquefy everything almost to go like a soup.
In fact, the thing which I even now think that whether I should buy a sucker and a machine, because every single day during eating, we have this moment where he's going all blue, something's got stuck. I have to do all of that to him. I can't do the Heimlich maneuver because he's much bigger than me and I can't go around him in that sense. But it is a scare. Every meal, I feel worried that is something going to go the wrong way today, because sometimes it's so difficult, especially things like chickpeas. It just gets stuck. He can't get it out. I can see his face is all gone blue and we're sort of trying to get it out. And this happens nearly every meal.
So it is scary. Mash it up a little bit.
Yeah. So that's still happening today, Shahid?
Yep.
Yeah, I mean, if I have the wrong item and it's not soft enough, sometimes, and I'm not paying attention. So actually, when I eat, I have to pay attention to eating and swallowing. So that becomes part of life. So even though I have steak or fish and chips or hamburgers, I have to make sure
very small pieces.
I cut it up into tiny portions to eat.
Even now, before we go to a restaurant, he'll have his, what is it,
Fortisip.
Fortisip. He'll have 2 Fortisip before we go, because when we get to the restaurant, probably, because we want to talk to our friends, so he can't talk and eat. So that's become a problem. You can't talk and eat. So he has his nutrition before he goes, and maybe we pack the food and bring it back always. He'll have like a quarter of the food and everything gets packed and we bring it home.
So I'm not bothered about asking that. Whichever restaurant we go to, whether it's a 1-star, 2-star, or a fish and chip shop, pack it up for me. I'll take it home and eat.
That's good. I'm glad that you're not missing out on anything.
Well, otherwise you would become very depressive if you said, all right, I'm not going to work with my friends because I can't eat.
Yeah.
So we always go out. I have all my meals, I have all the courses, but I won't finish them all.
Right.
But so be it.
Yeah. And when we were speaking before, you talked about some other things that you still have to consider, obviously. And you talked about other side effects or long-lasting effects from your surgery. You talked about eating and chewing and swallowing. Are there other things?
other things, what happens is, obviously I've lost a lot of weight, so I have no body fat. So as soon as it's a bit full, I have to wrap up. I walk down the street, people walk around in t-shirts, you know, I've still got a coat on, because I haven't got an ounce of fat on me. And for instance, a meal will take me about 45 minutes to eat. And it doesn't happen so much now, but even a year ago, if I missed one course, I would lose half a kilo straight away. So I had to make sure I weigh myself every day. I actually eat enough to maintain my weight, but to put on weight, impossible. So it's a real effort to eat. So 45 minutes of sitting at the table, having your dinner is not fun.
It's very tiring.
Yeah.
And the thing is, because of this cold thing, we were thinking of going to the Antarctica, but now Shahid says there's no way he's going to go there because he's not going to enjoy it. So unfortunately, that's one on our bucket list, which we can't do. Well, we did jump off a plane, so that's fine. After this, we said, let's do that.
Goodness me.
So yeah, I mean, so those are kind of, and obviously, because I can't put on weight, if I exercise too much, it's exhausting very quickly. So although I exercise, I walk, I do some weights on, I can't do anything intensive to say build muscle.
Yeah.
Can't do it. Because I won't be able to consume enough food to compensate for what I burn off.
Yeah, absolutely. Okay.
So you balance off what you can do and what you can't do. So where if you went on a very hectic holiday, which consists, so I mean, we went a couple of years back to Galapagos,
Yeah.
and I went snorkeling. Oh, exhausting. Absolutely exhausting.
And then to keep the thing on with the water, with the mouth control, all that was very difficult. So we did it. I mean, he did it, but it was quite, you suddenly realize that you can't do everything. Life has to, things that we wanted to do, we can't do that now.
So you change, make your compensations, and you learn to listen to your body. I mean, the early days, if I was tired, I wouldn't sleep in the afternoon. Now, right, those days are long gone. Now I'm at work from early morning right through the day. It doesn't matter. But early on, you had to, if you felt tired or something, rest.
You mentioned to me before that life has been pretty busy during this pandemic and the lockdowns. So it sounds like your energy levels are up. You tell people about what you've been doing.
Well, fortunately, I'm in the PPE business.
Right.
So ever since COVID hit, we have been inundated with work. So masks, gloves, aprons, gowns. We've been flying stuff in from China and the Far East constantly. So we've been working flat out. And unfortunately, nowhere to go out and enjoy it either. We're trapped at home like everyone else.
Yeah. Well, hopefully that will be changing soon.
And we've had both jabs, so we're looking forward to moving on. But yeah, I work a normal day where I used to spend perhaps a lot more time on the phone with customers. I spend time with customers I know well, who understand what I've been through. But to try and source a new customer who you don't know is much harder. So I've built up a new bunch of people on my telesales who do all that. And I manage the business on a more day-to-day basis rather than on the sales and marketing basis.
Yeah, yeah.
So your function changes a little bit.
Well, I really appreciate you telling us your story and actually sharing what it's like after the treatment, because that's something that you don't often hear about. So I really appreciate it. We've had some questions through from our attendees tonight. We're at 7 o'clock. I know we were due to finish at 7, but if everyone's happy to stay on for a few minutes, we could just ask a few questions. There's not too many. I'm hoping that we can get through them. Is that okay?
Yeah.
Great stuff. Thank you. So Catherine asked a question of Shahid. She said, when you got your diagnosis for the first time from the doctor, did you get any information on your condition and the options that were available for you for treatment? And have you any reflections on that?
Well, you don't have any options. You're told it's radiotherapy.
Right.
And this is something I have actually discussed with Vin before, that whether had I gone straight for robotics, my position would be much better off today than what it is, I presume. All the additional damage that's done because of radiotherapy would not have occurred. But delivering the normal leaflets, but you don't tend to understand enough about it. Fortunately for myself, with my wife being a medic, and all our friends have been medics as well, I've got a lot of additional information. But the hospital, they don't really sit down with you and say, right, this is your position, this is what's going to happen, the outcomes, or they didn't in those days. It was, right, the best way to treat it, radiotherapy, robotics was not an option.
No, nothing was in that way discussed. That's what I feel, that maybe more options should be discussed with the patient, and then if they want to choose whatever. We never got, second time when there was recurrence, that was it, you have to have the complete everything out. But we as patients, like Shahid said, because being in the medical field, I started doing a little bit of investigations to find out where else can we go, because we didn't want this sort of drastic surgery. And that's how we found Vin. And that's what I think from the patient's point of view, maybe if it wasn't us, maybe if we hadn't done all this investigation, Shahid would have had that artificial larynx and all that, isn't it? So that's what we feel a little bit. I think more patients should benefit. That's why when people were ringing me up, I was sending them all to Vin, saying go there, because you may have a chance of having something different, at least have a second opinion.
Yeah, yeah. Great, thank you very much for that. Nick, Nick, you've asked a question about the minimal jaw opening required for the transoral surgery, given that the previous radiotherapy might have resulted in fibrosis, limiting jaw opening. This is one for John and Vin, I would say.
Yeah, good question, Nick. So it depends a lot on potentially where the tumor is. The tumor is in the conventional place where it's at the back of the throat. And if access is not too bad, we could go down to 3 centimeters, no questions asked. 3 centimeters is when we could comfortably take out most cancers. It gets to less than 3 centimeters, it gets slightly tricky. If the tumor is further out, then using in the robotic system, we can actually use a digital zoom. So for proper robotic surgery, for conventional surgery, all 3 arms, the telescope and 2 energy devices, have to go into the patient's mouth, and then 2 other suctions to provide retraction, countertraction to be inside the patient's mouth. When it gets to less than 3 centimeters, that becomes quite tricky. So you can actually park the telescope outside the mouth, use digital zoom, and then insert the 4 other instruments in there. That's for more, for cancers slightly further forward. But 3 centimeters is the usual cutoff that we use. Anything less than 3, I think twice, thrice before offering robotics, and I'd offer them conventional surgery. And a lot depends also on how big the tongue is and how much swelling is there as well. So a number of factors. So for all patients, we actually take them to theatre, put them to sleep, and have a good look and assessment with all the robotic kit, but without doing the surgery, so that we can be absolutely certain when we get a patient to theatre for robotic surgery, that expectation isn't there. So with Shahid earlier, as Shahid said, we didn't know which way we're going. We did do an EUA, I think. We did an examination first, and we tried. It didn't work out, but we try and minimize the uncertainty.
That's great. Thank you so much, Vin. We've got another question from Addy. Addy says, thank you for sharing your very valuable insight into tours. Do you attribute good functional outcomes to careful patient selection? It's another one for you.
I think so. You're right, Addy, because this isn't a randomized control trial. This is where we're saying conventionally, the wisdom is that if a patient comes with recurrent cancer, minimally invasive surgery is out of the question. It can't be done because you don't get good margins. So we haven't discussed the margin issue here at all, but in scientific forum, this is exactly the point of debate. Because we're doing something minimally invasive, people tell us you can't get appropriate margins to offer a curative procedure. But you've seen from John's data, 70% survival at 2 years. That is pretty impressive, all said and done, because if we went down the non-surgical route of palliation or immunotherapy, we're still looking at 13 to 20% at 2 years. So the vast gulf between 70 and 13%. So patient selection is important, it's involved. And at the end of the day, if it's T1, T2, decent mouth opening, and even if it's multi-site, like if it involves tongue base and tonsil or tongue base and larynx, we still do it. So while there is patient selection involved, we also take out fairly large tumors. For example, Addy, the largest tumor I've taken out robotically measured 7 centimeters, 7 by 5 centimeters. So you can perform fairly large resection. The mouth opening is good, and the patient preserve is excellent. So multiple factors, and as you well know, as I suspect you're a professional from the way the question's worded, as you well know, it's very difficult to capture all this into one single outcome measure. But you're right in saying we can attribute good functional outcomes to patient selection. John's recut will have some outcome data attached to it when it's published. Have you got some information on that, John?
Yes, I mean, in terms of the diet, I don't know about it. Sorry, the mic. In terms of functional data, yes, we have what's going on at 1 year, and we also have how patients are managing in terms of like meats and things like Shahid mentioned. We haven't done the full analysis of that as yet, but it's certainly encouraging that there's a lot of people who, if you are able to swallow, if you are taking in things by mouth, then your chance at your last plot of taking on at least meat, so either a normal diet or a normal diet with what we call a liquid assist, are very good. There will still be a minority of patients that still need to have either top up or dependent on feeding through the gastrostomy tube straight into the stomach. But generally, if you get back to swallowing and if you work hard with a speech and language therapist, you can improve. I think what we also see is that in the recurrent patient, I'm not a speech and language therapist, so I'm speaking slightly after that here, but we work very closely with our colleagues here with the whole team. Is that the rehabilitation is much slower after surgery in the recurrent setting than it is after the primary setting, and really that just you need to manage the patient's expectations for that. It is a lot of work. Even at 1 year, you're not back at your baseline, and you're not at your optimal performance. So there is work to do after that, and people will continue to prove for a number of years after their surgery.
Thanks, John and Vin. Shahid, does that match your experience?
Yeah, it took me a good 3 years before I got to a level where I was much more stable, and now, I don't think there'll be much improvement at all. But up to 3 years, yeah, you would see improvements on a regular basis. So yeah, 3 years.
That's a good point, Shahid. Up to 3 years, unlike primary treatment where it plateaus at 2, this improvement goes on for a long time.
Yeah. One thing good happened is his sleep apnea disappeared. He doesn't have to sleep with that machine anymore.
You never mentioned that before.
Yeah, he used to have, when I met him, I thought he was a man from Mars because he used to wear all these things and sleep. But that's completely gone. So,
isn't that interesting?
The weight loss, isn't it? You have no more fat.
True. Yeah, I understand. We've had a question from Anson. Hi, Anson. You've asked if the surgeons could share the URL link for the published TOURS study involving the 16 centres. I can happily add that to our post-event email if you're happy with that.
Yes, we have the systematic review is published that we touched on at the end, but the 16 centre study is still in. We're still analysing it. So once it's submitted and peer reviewed, we'll certainly share that with Oracle, and hopefully they can tweet it out.
Right, thank you. And is that the Moses study, or is that separate?
The Moses study is separate. So the Moses study is something that Oracle has directly supported, but that's looking at the diagnostic uses of the robot in the primary setting. So for patients who present with cancer in the neck, but you can't find where it's come from. One of the procedures we do is to take away the back of the tongue, the tonsil on the back of the tongue, to see if we can find the cancer in that. So yes, that's still ongoing. We're still recruiting patients to that, but that's in 16 centres in the UK as well. So yeah, we're very happy with that.
That's great. So I just want to ask one final question of Shahid, if I may, before we wrap up, because it's now 12 minutes past 7. Shahid, I was going to ask you if you could go back and talk to yourself the night before your surgery with Vin, what advice or would you give yourself looking back then?
Wow. Really, you can go back and say, I wish I'd done something differently. Because we really don't know where you're going to anyway, isn't it? And looking back, perhaps there's not a lot I would have done differently. Perhaps the only thing I regret is having had the radiotherapy first, rather than having had the primary surgery.
Can we ask Vin this question, that are you doing more surgery now for primary robotically rather than giving radiotherapy, since the outcome would be much better if you did a primary surgery as opposed to having horrible tissues to work with?
So good question. This needs a slightly nuanced answer. So we look at treatment based on whether the patient has earlier stage diseases, T1 and T2, limited to regions in the throat, and whether it's HPV positive or not. In the T1, T2 HPV positive setting, where the neck disease is limited, a recent study that was discussed at the American Society of Clinical Oncology meeting just gone by in 2020, it happens every July, reported on 300 patients. And they showed that robotic surgery followed by lower dose of radiation, 50 gray in a select group, works as well as 60 gray. So the study is going through peer review in a major journal, and it is not, so we have different phases of studies. Phase 3 is a final arbiter, but this one is a phase 2 study. But the phase 2 data is so strong that the authors are saying this should potentially become standard of care. Again, carefully worded. And the reason why they say that is because with 50 gray or 60 gray in the right patient group after robotic surgery, the 2-year survival is 95%. That's kind of as good as it gets realistically. So that's one reason why. So, and that is in the UK, we have another study going on called the Pathos study, and a lot of patients are being recruited into Pathos to answer this very question. So in answer to your question about HPV positive disease, Sarah, yes, there is more robotic surgery going on. Yes, there is more laser surgery going on compared to 2013, definitely. When it comes to HPV negative surgery, HPV negative tumors, we are pushing surgery more on these patients because we think we will get exactly less of what Shahid had, get less recurrent tumors and more upfront cure with this. But that's an ongoing discussion, debate, and a lot of MDTs go through that on a regular basis.
Thank you.
I'm going to just say thank you to everybody for coming tonight, for asking such great questions. To Shahid and Sarah, thank you for sharing your story. We've had comments coming through saying you're both remarkable, and I think I would second that, absolutely. Professor Paleri, Dr. John Hardman, thank you too for sparing some time at the end of your long day. We really appreciate it. And everybody who's joined us this evening, thank you for joining us. We will send some information about the research that's been published, also about the work that Oracle is funding, that the team are doing, as John mentioned, looking at how primary tumours can be better diagnosed and identified. So I will drop you a line tomorrow with all that information, but for now, thank you very much, everyone, and good night.
Thank you.
Bye.
Thank you.
Right.
Do we do the awkward wave now? Okay.
Reach for the mouse.
Thank you. Bye.
Thank you. Bye-bye.
Bye.